Hi guys, this is our last module for vascular. Of course, as we know, everything that we learned in this class is really kind of just the foundation of vascular imaging. There's a lot more that goes beyond what we see as general text out in the clinical environment, and it is a little bit more complicated than some of the topics that we have talked about. This module is two parts. This first lecture is going to be a little bit more in-depth than the second one. Second one is kind of just cleaning up all of the topics that we've mentioned very briefly, talking about them in a little bit more detail, so kind of piecing it all together with that second lecture in this module. This first lecture, I will say, is a little bit abstract. It's very complicated because it's not something that we're seeing in the clinical world, and we're usually doing a lot of these exams with a totally different machine. So it has a very loose relationship to the general ultrasound world because it's really not using much imaging in general. We do some sort of vascular diagnosis in conjunction with imaging and these specific pressure machines, but it's not very often, and we'll talk about that as we move forward. But basically, when we're talking about these exams today, we're going to be using one of these machines. These are pressure machines. Usually they'll be called a PVR machine or an ABI machine, but really all that they're doing is they are allowing pressure to go into cuffs that we use for a lot of our exams, and then they pick up on the use of continuous waveform to show how that artery is responding to that pressure from the machine. So we're going to take it piece by piece here, but these are the machines that we're pretty much talking about. We're not getting an ultrasound image. We're not really using an ultrasound probe. We're using more of a continuous wave probe that, as we know from our physics class, does not give us any image that we can see on a display screen. So it's very abstract. And it's difficult because we can't rely on finding a vessel or finding a segment of a vessel with our screen. We have to know our precise anatomy, and we have to know that we are on the correct vessels that we're trying to get a waveform and a sample of. So these machines, like we said, they're giving pressure, they're analyzing that pressure, and they're also displaying spectral analysis. So we're getting a spectral window. Basically, it's like if we just had pulse wave Doppler on our machine and no image on our screen at all. That's going to be very similar to this type of equipment. So we're using our very precise anatomic location. So we have very precise anatomy knowledge. We're using a lot of pressure changes and sensitivity to motion to pick up in some of those blood vessels with the pressure changes. And then we're also using that spectral analysis or that spectral window to see, okay, does something look normal or does it look abnormal in terms of the waveform? So what type of exams are we going to be talking about? Mainly today, we're going to be talking about Doppler segmental pressures, plethysmography, photoplethysmography, and then we'll get into a little bit of penile imaging because that goes with the same type of application as photoplethysmography. So we'll talk about that a little bit today as well. And then the second PowerPoint, we're going to be covering the transcranial Doppler and some more of those surgical applications for vascular technology. So let's get started with our Doppler segmental pressures. This is going to kind of be like the bread and butter of vascular evaluation. So pretty much anytime we're using one of these machines to implement pressure changes in the body, it's going to be some form of a Doppler segmental pressure. And it's going to help us to assess the presence and the severity of arterial disease by seeing how those arteries, typically in the legs, respond to those pressure changes. Of course, with anything, there's going to be limitations to doing these exams. It's not going to be super indicative of a very precise diagnosis. So this means that it can show us something abnormal, but it doesn't tell us if that abnormality is a really tight stenosis or if a vessel is completely occluded. It also gives us a very, not very vague, but it gives us a vague location of where that disease is present. So we can kind of say, yeah, there's an abnormality in this area of the lower extremity arterial system, but we can't pinpoint, hey, at this exact spot, this is where we see a stenosis or inclusion. It also can give us false results by either having really high Doppler pressures. That's going to be seen with patients who are have morbid obesity, typically linked to diabetes, typically type 2 diabetes. Diabetes also gives us a lot of plaque accumulation in our leg arteries, so that's going to give us elevated elevated Doppler pressures that are going to be falsely giving us some sort of arterial disease. Also, chronic kidney disease, any kind of renal abnormality is going to give us abnormally high pressures, atherosclerosis in the arteries for whatever it may be. Of course, it's going to make those pressures even higher to compress that area, and inappropriate cuff size. So when we're putting blood pressure cuffs on our patient, if we're not picking the right size or length, that could give us an abnormally high reading. Any patient who has congestive heart failure or overall systemic cardiovascular diseases is also going to result in an abnormal reading, but more so in a decreased sense. So we're going to see abnormally low readings in a patient who has congestive heart failure or any kind of cardiac output disease. And then any patient who suffers from vertigo, our patients need to be laying down for this exam and having a lot of pressure on certain arteries or literally constricting blood flow. So that has another response to the patient as well, where they can get very dizzy even if they're laying down. So a lot of things we have to be aware of, and not everybody is a perfect fit for this exam. There are some patients that we can't do this exam on, which we will talk about in a second. The technique for this exam, so you're probably like, what are we doing with blood pressure cuffs? What are we inflating? What are we looking at? Like, why are we doing this exam? The technique for this, we need our patient laying down. They have to be supine. They have to be resting for at least 20 minutes before we even start. That is so that we have no hydrostatic pressure working on the body, and that we also have no quote unquote effects of exercise working on the body. We need our patient completely relaxed and laying down flat. That's where that vertigo is going to come in. If our patient can't lay flat, we can't do this exam with them sitting up. Even in this picture here, we probably wouldn't be giving the patient that pillow. And if we needed to give the patient a pillow, we would make sure that it is just underneath their head, not underneath their neck and their shoulders like that. So completely laying flat, supine for at least 20 minutes to let that heart rate go back to normal. Even if your patient is just getting up and walking from the waiting room to the exam room, that's still going to have an inherent increase in their blood flow. So we need them to calm down even just from that short walking distance. Absolutely no hydrostatic pressure. So everything is level to the heart. We need to make sure that our blood pressure cuffs are appropriately sized and that we're placing them correctly on the patient. You want to make sure that they are placed straight on the extremity. There's no angle to them. There's no obliquity to them on the patient. That can be a little bit tricky when we have sometimes women with curvier legs, curvier thighs. Sometimes we can put the cuff on a little bit on an angle, and we have to make sure that we don't do that. We also don't want to be putting a blood pressure cuff on top of an area where the bone is very prominent. So we're not putting a cuff on top of the knee. We're not putting a cuff right along the ankle joint where our little malleoli poke out. That way, when we go to inflate those cuffs, it's not counter pressure from those bones. We also want to make sure that the cuffs are on nice and snug, but not too tight where they're already constricting blood flow. We want to make sure that the cuff bladder is right over where the artery is. So we want to make sure that where we're going to get the reading from and where that pressure is going to come from is along the medial aspect of our legs. We don't want to have the cuff on the outside because that's really nothing in terms of vascularity on the lateral aspects of our legs. All of our vessels are on the medial aspect. We want to make sure that the width of the cuff is at least 20% greater than the diameter of the limb. So if our patient unfortunately has a limb girth that is way too big for the cuffs that we have, we're not able to do this exam on them. So you want to make sure that we're not just barely closing that cuff around somebody's thigh. You want to make sure that you have a little bit of room for that cuff to expand with pressure, knowing that it'll stay on the patient. We then use continuous wave Doppler. So we're using a transducer, but it's not an imaging transducer. It's a continuous wave Doppler transducer. It's very small. You may have seen it used in hospitals where they go and they put it on a patient's toe to check their blood supply or to check their pulse. Very similar to that. Or if you've been to the OB's office and you've seen people with the fetal Dopplers, they're trying to find the heartbeat, right? They're not using any imaging to find it. They're using the sound of that pulse to find it and to get closer to it. So this is where our anatomy precision comes in. So we have to be able to say, okay, when I'm looking at the base of the ankle right along the top, I know that that's going to be my anterior tibial artery turning into my dorsalis pedis artery. I know that when I am Dopplering at the base of the first toe, that I'm looking at a digital artery. I know that when I'm looking around the lateral malleolus of the ankle, I'm looking at that extension and that continuation of the PTA, right? So these are all things that you have to make sure you're aware of with that lower extremity arterial anatomy. So moving forward with this, let's talk about the cuffs a little bit more, and then we'll get into what these readings mean and kind of how our exam goes step by step. So we just talked briefly about the cuffs, right? Make sure the bladder's over the artery, make sure the cuff is long enough depending on the patient's like leg girth, make sure that it's not over a bone. But there are two different methods that we can do depending on the equipment that we have. So we have a 4-cuff and a 3-cuff method. Typically, this is technically considered a 5-cuff and a 4-cuff method, but I'm not going to throw you for a loop with that. We're talking about 4-cuff and 3-cuff on the legs. When we're doing segmental pressures, we use a pressure in the arm. We use a brachial pressure to help as a reference. And then we get sort of a whole body systemic value when we do that. So that's why I'm kind of saying it's either a 5-cuff or a 4-cuff, because we're not including the cuff on the arm. So we're using either 4 cuffs or 3 cuffs on the patient's thighs. We're always doing this exam bilaterally. This isn't an exam that we're just going to do, hey, we're just going to do the right leg. We don't do that. We do both legs and we do both brachials. So we have it always done bilaterally. On the 4-cuff method, we're doing one high up on the thigh. We're doing one above the knee, so lower thigh. We're doing one below the knee, so upper calf. And then we're also doing a 4th one right at the ankle. Now the ankle one is going to matter most prominently for both of these methods. So the ankle and the brachial, you absolutely have to have those. Where it gets variable is in terms of the thigh cuffs. So with the 3-cuff method, instead of having 2 on the thigh, you just have 1 on the thigh. Typically, this cuff is going to be a little bit thicker, so it's going to cover more of a surface area, but you're still having 1 below the knee and 1 at the ankle. So you're always going to have 2 in the lower leg. You're always going to have 1 on the brachial of the arm, but then sometimes you can have either 2 or 1 on the thigh. And the way that we do this exam obviously would vary in terms of what method we're using. So let's see what those look like. So here on the left side, 4-cuff method, on the right side, 3-cuff method. You can see with the 3-cuff method that thigh one is much wider and kind of like thicker surface area than the 4-cuff. So again, depending on the equipment that you're using, you could use either of the 2 methods. Both of them have their pros, both of them have their cons, which we'll talk about in a second. But look at the 4-cuff method. See how those blood pressure cuffs are nice and parallel to each other. They're not on an angle, they're not over the knee, they're not over the bony parts of the ankle, and they're sitting directly straight across. Even though she has like curvy upper thighs, we're not following the angle of her thigh like this. We're going straight across. Everything is parallel with each other, parallel on each leg and parallel with each leg. And same thing with the male patient over here on the right-hand side. Male patients tend to be a little bit easier since their legs are just a little bit more narrow. They don't have natural curves to their upper thighs. So pretty straightforward here. So let's talk about the pros and the cons versus 4 cuffs and 3 cuffs. If we are using 2 cuffs on the thigh, so the 4-cuff method, we're able to get a little bit more detail in where an abnormality could be located. So we could be seeing more definition of location of disease. But because we're going to be inflating 2 separate cuffs, that can give us a falsely elevated reading. So when we talk about our readings, that'll make a little bit more sense. Now, when we have the 1 thigh cuff, we're not artificially elevating those readings as much as we are with the 2 thigh cuffs, but we're not getting as much precision in terms of location of the disease. So again, trade-off, and it really all depends on the type of equipment that we're using. Important to note that as the girth of a patient's limb increases, so are our pressure readings. So that means that as we add pressure to a patient's anatomy, if their leg is bigger, it's going to require more pressure to get that artery to be affected because there's more soft tissue for us to compress through. So that kind of goes along very closely with the patient's medical history when we're evaluating these pressure readings. So it's important to note that we're not going to see the same range of pressures in a patient who is very, very, very thin as we would the patient who is more in that obesity category. Okay, so how do we do this? We have our blood pressure cuffs on, kind of regardless of 3 or 4 cuff. We have our continuous wave Doppler transducer, and we know we don't have any imaging. So we're using that 8 to 10 megahertz Doppler probe. That's kind of the frequency of these probes. We're holding it the patient's medial ankle, and we're typically going to be searching for the PTA. That's going to be at the medial aspect of the ankle. You can use the DPA, which, as you would know, you wouldn't see it at the medial aspect. You would see it at the top of the ankle going into the foot. So for reference sake for right now, we're going to particularly be using the PTA, the medial aspect. So we're holding our continuous wave Doppler probe 45 to 60 degree angle in that medial region, kind of around that medial malleolus of the joint. That degree of angulation is going to depend on, is it a chunky ankle or is it a really thin ankle, okay? You're also going to be using a handheld blood pressure cuff or an automatic cuff inflator. Now, if you're ever working in a vascular lab and they give you a handheld blood pressure pump, they shouldn't be doing these exams. Okay, so the machines should have the feature of doing an automatic cuff inflator. So you can either push the button on the machine to inflate the cuff, or it comes with a little remote, and you can use the remote to tell the machine, hey, inflate the cuff right now. So that's what we're going to be referencing here. I don't know how you would do all of this using a handheld pump, but some people, I guess, have. So we're using that continuous wave probe, looking for the PTA, the medial aspect of the ankle. And as we are getting that nice waveform, so we're holding it on an angle, we hear it, right? It's boom, 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 boom. We're going to then tell the machine to inflate the cuff. Now, I should have backtracked a little bit here. We want to do this at the brachial first. We always do the patient's arm first, and we usually will Doppler at the radial. Okay, so we put the blood pressure cuff on their upper arm for the brachial artery. We use the same continuous waveform transducer down at the radial part of their wrist. We're hearing that radial artery, boom, 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 boom. We're inflating that brachial cuff, and then we're going to keep inflating it until we don't hear any blood flow. So there's so much pressure in that cuff that it compresses that artery completely, and then we still don't stop. We inflate it 20 to 30 millimeters of mercury, right? So 20 to 30 units of pressure beyond where we stop hearing that flow. So this exam is pretty uncomfortable for these patients. Then, once we're at 20 to 30 units of pressure beyond where we heard that flow stopping, we let go of the pressure. Okay, so we say to the machine, okay, stop inflating and let that pressure out of this cuff. Slowly, after a few seconds, we're going to hear some boom, boom, boom return. We're going to hear that blood pressure or that pulse starting to very faintly come back. The very first arterial sound that we can hear is going to be what we're looking for. That's going to be our systolic pressure returning, and that's what we're going to measure. So we're doing that in the brachial of the arms, and then we're moving down to the feet. We're going to the ankle. We're looking for that PTA. That continuous wave Doppler is going to stay there the entire time. You're still going to be Dopplering that PTA throughout the whole exam. What we do from there after we do the brachial is we start with the cuff closest to the continuous wave transducer. So we're starting with the ankle cuff. We're telling the machine, hey, okay, we're ready to inflate. We're inflating until we don't hear it anymore. And then we're still inflating another 20 to 30 units of pressure beyond. Once we're 20 to 30 units of pressure beyond where our flow stopped, we're then saying, okay, you can stop increasing and actually you can let that pressure out. Where we hear that first audible sound, it's going to be that systolic pressure. We're measuring. Okay, we're waiting a minute for the body's heartbeat to get back to normal because we just put it through stress. Then we're moving up. So if we're using the 4-cuff method, we're then going to use the below the knee cuff. So we're going to tell the machine, hey, now inflate the cuff that we put below the knee. Same thing, we're still holding it at the PTA. We're still getting an arterial waveform. Now we're telling that cuff one up higher, go ahead and inflate 20 to 30 units of pressure beyond where the flow stops. Same thing, gonna let that flow come back. We're gonna let that pressure stop. First audible noise is gonna be the systolic pressure at the cuff below the knee. Sit for a minute, moving up. Then we're gonna do the above the knee one, right? So lower thigh. Same thing, inflate, deflate, measure the first audible. Then lastly, we're doing the high thigh all the way up at the top. So we're starting with the arms. We're always going to do the brachial first. Really, for any vascular exam, we always reference the upper extremity. So we're always going to do the brachial first, and then we're working our way up from the ankle, depending on what cuff method we're using. So here is what this is going to look like on our screen. So here is the kind of general view of what our transducer would be doing. We're holding it on a very steep angulation to get that PTA. Again, if you wanted to use your DPA, some places actually require you to use the DPA. You would look more anteriorly on the joint of the ankle and the foot. And we would, again, just work our way upward. Now, when we're Dopplering, that's going to be all of this right here. So here's our nice PTA pulse. Boom, 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 boom. All of a sudden, while this is happening, see right here, we're telling the machine, okay, start increasing your pressure. Increase, 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 increase. And then watch what happens to the waveform as that pressure reaches a certain point. It gets smaller and then it completely goes away. So we're still pressuring, we're still adding pressure as we go. And then once we kind of stop here, it's decreasing our pressure, decreasing, decreasing, and at a certain point, once it decreases to a certain point, we're going to hear that return. So the first audible is where we're setting our measurement or setting our caliper, and we're saying, okay, it was at 133 units of pressure or millimeters of mercury is when we had our systolic pressure return in that section. Now you would think that you might want to measure it right where it returns back to its normal pulse, but that's not what we're looking for here. We're looking to see, okay, at what pressure can our arterial system compensate back to normal after going through a stressful event. So look at the waveform, normal pulse at the left side of the spectral window. Our pressure starting to increase. We see it kind of stopping like right at this level, right? We kind of see our blood flow stopping like here. But we kept increasing, another 20 to 30 millimeters of mercury. And then at that point, we said, okay, that's enough. We can stop. That pressure is decreasing. And as it's decreasing, we're going to hear a few seconds later this. And right at that, we're getting the 133 millimeters of mercury. So that's the information that we need. So how do we interpret this? What do all these numbers mean? Why do we care? So when we're calculating pressures, it's giving us a lot of information, but we kind of are mainly looking for an ankle brachial index. You've probably heard of an ABI before. That is going to be something that we use for a lot of exams, and it gives us kind of broad, whole systemic information of our cardiovascular health, right? Or the standard pressure that that patient's body is functioning under, with a little emphasis on the lower extremities. So we take the ankle pressure of each leg and then we divide it by whatever brachial reading was the highest. So we don't take the right ankle and divide it by the right brachial. Same thing on the left side, we don't do that. If the right side, if the right brachial is higher than the left brachial, we're going to use that for both ankles, whichever brachial is highest. So we're taking the ankle pressure of each leg and dividing it by whatever one is highest. If we have anything that is greater than or equal to 1 for this index, that's normal. Okay, we want to see a bigger difference between the two, between the upper extremity and the lower extremity. If we see that number starting to get smaller, that's going to indicate some sort of arterial disease, right? So some sort of maybe true claudication, maybe it's minimal, maybe it's just some kind of obstructive disease in one area. Maybe we've moved past claudication and we're in rest pain, right? We're kind of bordering and teetering on that level of ischemia soon. So we want to see a number greater than or equal to 1. That's going to show us that there's a drastic difference between the upper extremity pressures and the lower extremity pressures, as it should be, right? We have more pressure in our ankles than we do in our arms. So a decrease in 20 to 30 millimeters of mercury between any two levels is also going to suggest a significant obstruction that has occurred in that location. We're also going to use the interpretation of waveform patterns and velocities in addition to that ABI. So an ABI is really just giving you information about the ankle pressure and information about the arm pressure. But what about all those other pressures that we took in between? So we're also using that to help give us a full diagnosis. So ABI is kind of the absolutely necessary calculation that we have to do, but we do still care about the other velocities and the other pressure readings from those levels that we just performed. Effects of exercise. So we said at the beginning of this, our patient has to be supine, right, for 20 minutes. Their heart has to get back to normal, no hydrostatic pressure. There are certain instances and certain indications where we actually want to use exercise to our benefit. So if we're laying down and we're resting, but we don't have any positive readings, right? We don't have anything that's showing up abnormal or showing up weird. But I say to my doctor, okay, it only hurts when I'm walking, right? Yeah, it might not be a serious problem where I'm worried about ischemia, but I might still want an answer to this problem. So we want to implement some of those conditions in which they produce clinical symptoms. So we want to sometimes use exercise to help us with a diagnosis and to help us determine if there is something abnormal in terms of claudication or pseudoclaudication. So we're doing the standard segmental pressure exam at rest. So that whole thing that we just talked about, we're doing the cuffs on the brachials, the 3-cuff or the 4-cuff on the legs, inflating, deflating, measuring the pressure. And then in addition to that, we're going to have our patient walking on a treadmill. We're going to put them on a 10-degree incline for 1.5 miles per hour for typically about 5 minutes, or until their symptoms start to come on to the point where it makes them stop. Sometimes that's going to be more than 10 minutes. So again, it's all going to depend on the patient. If it's a young patient, we don't want to just stop them after 5 minutes because they probably don't have their symptoms yet. So maybe we'll go up to 10 minutes, sometimes 15, maybe 20. When we have them walking, it's going to cause reactive hyperemia, where the body is going to say, well, I need blood supply, right? Anytime we're walking, anytime we're moving, our peripheral system, the arteries in our peripheral anatomy are going to say, okay, I need more blood flow getting to these tissues, right? Because there's a lot of exchange going on. I need to keep it supplied. This addition to the segmental pressure exam that we just talked about is going to be able to help us determine, is it true claudication, meaning you have it regardless of walking or not, or is it pseudoclaudication? Do we have a collateral system going on? Is there network collateralization happening? Because if there is, we might not see as drastic results. And the technique of this, we want to make sure that we are doing this very effectively. So yes, we do the whole segmental pressures, but then when we're doing this with the patient walking, we need to take these waveforms and take these pressures immediately after they exercise. So it's not like, okay, we're going to get off the treadmill. Can I run to the bathroom real quick before we get into the next part? You can't do that. Or, I need to catch my breath before I lay down. No, you're getting off the treadmill. You're doing your pressures immediately. So you're doing your ankle first, which is a little different after the fact. We're doing the symptomatic leg first, and we're doing the ankle first. The symptomatic side first, and then the ankles. Then we're going to go and do our brachials. We're not doing a full second segmental pressure with this. This is going to just be an ABI after they exercise. So we're just doing the ankles and we're just doing the brachials. If it's normal, so if our patient doesn't have any true claudication, anything, nothing to worry about, our ABI should increase immediately, right? Because they just exercise. So we would expect to see greater pressure differences throughout the body. If it's abnormal, our ABI will decrease. And then from there, we're going to retake those ankle pressures and brachial pressures every 2 minutes until the pre-exercise pressure occurs, right? So we're looking back at that segmental pressure that we performed while the patient was supine, right? The normal segmental pressure that we performed. We're looking to see what those pressures were, and then we're performing the post-exercise readings every 2 minutes until those levels come back to normal. Okay, so it's a lot, and these exams take a long time, and your patient has to be cooperative for this. So, of course, there are going to be contraindications for us doing any kind of exercise, but then also for the Doppler segmental pressures in general. So if our patient can't walk or exercise safely, we're obviously not going to put them on a treadmill. There is an option for stressing the peripheral system safely, and that is going to be similar, but a little bit more intense than the standard Doppler segmental pressure. We inflate the cuffs 20 to 30 millimeters of mercury beyond whatever the highest brachial pressure is, and then we hold that for 5 minutes. So we're literally cutting off their blood supply for 5 minutes. It's very uncomfortable. So these exams we're not doing very often. There are other exams that we can, particularly with exercise, like this Doppler segmental pressures, we are doing that quite a bit. ABIs, we are doing quite a bit. But the effects of exercise, there are other things that we can do to get a diagnosis that aren't having them on a treadmill if it's not safe, or literally producing ischemia in their tissues for 5 minutes to the point where like they're crying on the table. So again, a lot of contraindications for this. There are other options. So this is not the end of the world, but you just have to understand that this is something that some places will make their patients endure if they have to. So we talked about this mainly in reference to the lower extremities, getting information about the arteries in the legs. We can perform this in the upper extremity. I actually personally have never performed a Doppler segmental pressure full exam in the upper extremity, but it's the same concept as the lower extremity. Of course, we're not going to be putting 4 cuffs on somebody's arm. We're just going to be putting 2, one still at the brachial and one at the forearm. And then we're taking waveforms a little differently than legs, where we kind of just stay at the PTA. We're taking waveforms kind of as we go up. So we're going to be Dopplering the radial and the ulnar as we inflate the forearm cuff. We're also going to be evaluating the brachial at the antecubital fossa. So we'll be Dopplering the brachial at the bend of our elbow while that brachial cuff is inflated. And then our axillary and subclavia in some places don't even need you to inflate a cuff because it doesn't matter because those are both located higher or more proximal than where that brachial cuff is going to be located anyway. So not really too much information in terms of interpreting these. Again, not performed very often, really not super helpful. We should see a decrease in pressure from the upper arm to the forearm. I'm sorry, we should not see a decrease in pressure from the brachial to the forearm. If we do, it should be minimal, so anything less than 15 millimeters of mercury. When it is greater than that, so meaning when there is a drastic decrease in pressure between the two segments, it's going to indicate some sort of brachial artery obstruction distal to the brachial cuff, so kind of heading more towards into the forearm, or an obstruction in the radial and ulnar arteries, or maybe just one of them. Again, not like super precise, right? Kind of just says, yeah, there's something going on in those arteries, in the arm arteries. So not super precise, not very diagnostic, definitely needs follow-up interpretation. An Allen test. So this is typically an add-on test that we can do for an upper extremity Doppler segmental pressure. This sometimes can be done on its own, but we're usually going to be doing this with that upper extremity Doppler pressure. We use it to diagnose the patency of the arches in the hand and of the wrist artery, so the radial and the ulnar. Basically what we do is we feel for the radial artery and we compress it. As we're compressing on it, we're going to have our patient clenching their fist and relaxing. So when the patient clenches their fist and we have pressure on the radial artery, we're compressing the radial artery, it's going to lose color, right? Normally, it's going to get its color back when the patient relaxes their hand while we're still compressing. And that's because relaxing their hand allowed the ulnar artery to compensate for the rest of that blood supply into the palmar arch. Now, if we're still compressing, the patient clenches their fist, they lose color, they relax their wrist again, and it still doesn't come back. That's going to indicate that our ulnar artery is blocked and that our palmar arch has a dependency on blood flow from the radial artery. So if you kind of just do that to yourself, you're going to be compressing your radial artery, clench your fist, right? You're going to lose color. You relax it. If the color comes back, everything's good. If you relax it and color does not come back, that's saying, okay, not only are you creating a blockage in the radial artery right now, but the ulnar artery is not getting any blood supply to that hand. So it's kind of a neat little test that you can do on yourself, but it usually is going to be used in conjunction with something else. It's not, again, super diagnostic. Finger stress test. This is something that we do with and without cold sensitivity. This is usually going to help patients to identify primary or secondary Raynaud's. And again, something that you can kind of do at home. It's like a fun little thing that you can try out with your family members. But basically, when we're doing it with cold sensitivity, we are going to be submerging hands into very cold water for 3 minutes. And then you are going to be taking waveforms. Well, you can kind of do this on your own, like visually, but in the clinical world, you're going to be taking waveforms and pressures immediately after you get them out and then 5 minutes after. During that time, you do want to be documenting symptoms of the patient. Without cold sensitivity, you are going to be doing Doppler waveforms and velocities of an upper extremity. You're doing pretty much a segmental upper extremity Doppler segmental test. You're going to prove palmar arch patency, and then you're going to be putting cuffs on patient's fingers. You're going to be doing waveforms and pressures to obtain that. And then from there, what are those waveforms and pressures going to look like? You're doing, quote unquote, a finger brachial index, so kind of like the ankle brachial index, but with your finger and your upper arm instead. And you're really looking for normal waveforms to come back within 5 minutes. So with the cold testing, if your color does not return back to your hands, that's going to indicate something abnormal is going on with the wrist arteries. Right? So something in your palmar arches are not getting the blood supply that they need to. So your hand color should come back within 5 minutes. If we look here in terms of our waveforms interpretation, we have immediately after cold submersion, that waveform is very monophasic, kind of just like a little hump there. We're not getting much of a clear arterial supply. And after 5 minutes, it actually even gets worse. So that's obviously going to be abnormal. After 5 minutes, we would want to see something looking more so like this. We can expect to see this immediately after cold, right? Because that really cold temperature is going to make those arteries vasoconstrict, so you're not going to get as much blood supply traveling through there. But you would think that as heat returns back to that tissue, you would be getting more of that normal appearance within 5 minutes. Plethysmography. Okay, so this is also known as volume plethysmography. We use this in combination with those Doppler segmental pressures. It's a little bit more helpful in terms of accurate diagnosis, and that's why we usually do it at the same time that we're doing the Doppler segmental pressure. It's the same type of technique, but we do things just slightly differently. So because they're very similar to each other, we usually do them both at the same time. So this is going to help us differentiate between claudication and non-vascular causes of pain. It can help us document functional aspects of vascular disease. Do they have collateral networks being formed? It gives us a little bit more information about the level of obstruction. It can help us assess results for medical or exercise therapy. Usually with this, we're using a PPG sensor, which is photoplethysmography, which we can add in the toe interpretations to this. Limitations of plethysmography, we can't specify a single vessel because it just measures the volume changes in a large segment of that limb, depending on where the blood pressure cuff is. Again, can't distinguish between major vessels or collaterals. And then obesity is going to limit the overall quality of this exam. So what is the difference between this? Like we said, very similar to Doppler segmental pressures, but instead of filling the cuffs an extra 20 to 30 millimeters of mercury beyond where the blood flow stopped, we just put in a fixed amount of air into the cuffs, and we see how the artery responds to that. So we're not looking to get the blood flow to stop. We're looking to see how the blood flow responds to a little bit of pressure from the outside. So the cuff is going to not only be able to put in that pressure for the patient, but it's also going to be able to pick up what it's getting back from that pressure. So the cuff is going to convert the volume changes in the vessels with that amount of pressure that they put in, and the machine is going to display that in a way that shows us a waveform. The diagnosis is going to be interpreted by what that waveform looks like instead of that pressure number or pressure difference between segments. So very similar. We're not really doing too much differently, but we're getting different information. We're almost like making the blood pressure cuff and the machine do a little bit more work with plethysmography, whereas the Doppler segmental pressures, it's kind of just like solely reliant on us. So this is what the system is going to analyze for us. So again, still doing a brachial. We're still doing either a 3-cuff or a 4-cuff. And this example, this right up here, these two are not of the brachial readings. These are the brachial readings. So of course we would want to be doing the right brachial if we're doing an ABI with the previous segmental region. I think that one's a little higher. But mainly what we're looking at with these is we're looking to see, okay, does it look triphasic? Does it look biphasic? Does it look monophasic? So if we look at the patient's left leg, we have the same amount of pressure being inserted into the cuffs, and that's going to be this gain 35%. You see at the bottom, right? So we added 35% pressure. Left popliteal, right? I'm kind of starting at the patient's like lower leg. I'm sure we had previous readings up higher in the thigh. The left popliteal with 35% pressure, sure, it's still nice triphasic. Posterior tibial artery, very triphasic. Even the DPA, triphasic. Left toe, beautiful. That's using a PPG sensor. That's why it looks a little different, but that's still normal. We'll talk about that in the next slide. And also, it doesn't have the same pressure reading. See how it says 100 there instead of 35? Those sensors are a little different. But those popliteal, PTA, DPA, all look beautiful, triphasic, kind of unaffected by that pressure. Now, if we look at the patient's right leg, still the same amount of pressure as the patient's left leg, but we don't have any triphasic waveforms. So this patient's whole area, the popliteal, the PTA, the DPA, their whole lower extremity, we don't really know about the thigh. Even, well, yes, we do, right up here, the femoral. That's still monophasic, right? That's all abnormal. So that entire right leg has some sort of disease going on because it cannot display a normal triphasic waveform with that 35% pressure from the blood pressure cuff. So that's what we're looking at with this. With the Doppler segmental pressure, we're looking at that pressure number. We're looking to see, is there a drastic difference in pressure readings between two segments? And if there is, what does that mean? What is the systemic pressure with our ABI calculation? Whereas this, we're seeing, okay, like why can't these vessels respond under a certain amount of pressure? What's going on in these sections? It's giving us more of a phasicity that we have to look at. And their right toe still looks good, so that's good. At least their right toe is getting blood supply to it, but the rest of that right leg is undergoing some kind of stenosis or disease. PPG. So we just said that this is a little bit different. It's kind of a sensor that we use. Stands for photoplethysmography. We're also doing this in conjunction with Doppler segmental pressures and regular plethysmography. So it's like a 3-for-1 exam, guys. You do a Doppler segmental pressure, you do a plethysmography, and you do a PPG on top of it. So it's fun being a vascular tech. This is a type of sensor that we put on the skin. It's going to help us detect very faint blood flow and movement of blood flow in the cutaneous tissues. So this sensor is very sensitive, like super, super sensitive. We have to make sure that it's stable on the patient's skin, that we keep it covered because it can be affected by light. It's an infrared light source that actually receives reflected backscatter from the blood vessels in the tissue. So we have to keep it covered away from any other light because it can mess up the reading. And what it is it's really useful for determining if there's tissue death in a patient's toes, if we're questioning amputation, if we are questioning if there's any blood supply getting to their toes and we can't find anything on Doppler, maybe they have like a really severe stenosis or occlusion. We obviously know that the toes are going to be first affected. They're the first to go in terms of amputation. So we want to make sure that we are picking up blood flow in those tissues. We don't have to use them just on the toe. We do use them with penile imaging because, again, that's very sensitive, soft tissue anatomy that we want to be picking up blood flow in. We'll get to that in a minute, but let's see what the typical waveform looks like of a PPG sensor. So on the top there, just kind of like a nice arterial pulse. Doesn't really give us too much information because, again, it's picking up blood flow in very small tissues. So we're seeing an upstroke and a downstroke, pretty clear cut, right? Pretty rhythmic, nothing really much to write about it. Technically, it does look monophasic, but again, we're not getting like a standard pulse wave Doppler or even a continuous wave Doppler. It's literally just picking up the motion in the cutaneous tissue. Clearly, the one on the bottom is abnormal. It's not really picking up anything. There's no clear waveform. It's kind of just picking up static. So that's going to be more of a severe toe obstruction or tissue obstruction. So penile imaging, we use a lot of these applications that we've talked about for penile exams. There are two types of penile exams. One's invasive and one is not. One uses imaging and one does not, and one uses medication and one does not. So the non-invasive form of penile imaging, this is known as non-imaging. So it's using more of our blood pressure cuffs and PPG sensor to get a better idea of the blood supply going to the penile tissue, whereas the invasive part of this diagnosis is one that includes medication. So this does not include medication. This does not include any imaging. So it's very helpful in the diagnosis of impotence. It's also related to peripheral vascular insufficiency. So a lot of the major blood vessels that supply the male reproductive system, they could be blocked, and therefore that the genitals on the patient are not getting the blood supply that they need, and therefore not working properly. Patient care, this is super, super uncomfortable for these patients. They have extremely high levels of anxiety. First of all, it's an ego thing as well. They are there because of a potentially embarrassing diagnosis or something that they don't want a lot of people to know. And then they're coming in for this exam where they have to, really have all of their genitals exposed to multiple people because you're usually going to be in there with the physician as well. So it's a lot. It's a lot of anxiety for these patients. These patients also typically have a sensitivity to the medication option that we can use with the invasive penile imaging. or they have some sort of clotting condition or medication that they're on where it makes it so that they can't have that injection. So we don't prefer to do the non-invasive penile imaging. They definitely prefer to do the medication with the imaging because it gives us more of a clear diagnosis. And it helps the patient a little bit more, whereas this, it's a little bit more subjective. So the technique with this, of course, we want to keep them as covered as possible, but we do have to put a blood pressure cuff on their penile tissue. We're taking Doppler velocities of the bilateral common fem, up in the thigh, up in the groin, and then the PTA and DPA. We're calculating an ABI, so we are still doing one on the brachial as well. And then we're looking to see if there's any poor arterial flow to the lower extremities from those major arteries that may be affecting the blood supply getting to that penile tissue. We also are using that PPG sensor as what we call, quote unquote, endpoint detector. And that's really saying, okay, we're picking up blood flow in the very distal tissues of the penile shaft, and that's a good thing. You want to see that the tissue is getting blood supply, so that we're not questioning a bigger occlusion elsewhere. The cuff is kind of standard size. We can use these cuffs too on the toes to keep the PPG sensor in place. So you want to make sure that, of course, you're using as much of a disinfecting cleaning product as possible. We can't obviously sterilize these cuffs, so you want to make sure that you are cleaning them as well as we possibly can, to keep our patients safe between exams. So here's what the patient would typically look like. We have our brachial cuffs up there, and then we're doing a thigh cuff to potentially get some of those readings up from those more major vessels. And then that penile cuff that we will be putting as that endpoint with the PPG sensor as well. So our interpretation of this is going to be pretty clear cut. We're still getting information from our ABI. Of course, anytime we're doing that, we want to have kind of a whole system-wide evaluation. But then we're also doing a penile brachial index as well. Anything greater than or equal to 0.75 is going to be considered normal. Anything less than that is questionable. And then if we see reduced pressure, it's going to indicate that there might be some kind of proximal arterial disease going on with the iliacs or the aorta itself. So if pressure itself is very low, we need to kind of do some further imaging. So we might want to end up doing a full Doppler segmental pressure with the plethysmography. So definitely looking at things in a bigger picture. Now, the invasive aspect of that, this, like we said, is a little bit more helpful. It's usually going to be the first option that patients will be suggested to do. This is a type of imaging, so we're going back to our ultrasound screen. We're using our vascular probe, so 7 to 9 megahertz transducer. Sometimes, though, you definitely want to use the 12 because we're looking at arteries that can be very small. So although our 12 or our 15 is not really that great at vascular supply, it'll at least help us find them. So that can be, a little bit of a back and forth with the transducer selection. Pre-injection, so pre-medication, we're going to be looking at the cavernous arteries of the penile shaft, which we'll see in a second. I have like a nice diagram of what they look like. And then in transverse of those cavernous arteries, kind of in like the mid part of the penile tissue, we're going to do a transverse AP measurement. We're going to do a velocity of each of those, measure that, and then we look at the dorsal vein, which is going to be on that dorsal aspect of the penile shaft. We then do the injection. So the medication is going to be injected into the lateral aspect of the proximal penis, and then we're going to wait for the erection to be induced from that medication. 1 to 2 minutes after the injection, with that medically induced erection, you want to be repeating those pictures. So we're still looking and doing a transverse AP measurement of the cavernous arteries. We're doing velocities, measuring that, the cavernous arteries, and the dorsal vein velocity as well. After the injection, that erection should subside within 3 hours. If it does not, that is when patients are instructed to go to the hospital because that is going to have an effect on their blood supply and ultimately on that penile tissue. So if it lasts longer than 3 hours, they need a counter medication to get that to go back down. So when we are looking at the anatomy of the penile tissue, this isn't really something that we've learned too much about. We know about the scrotal anatomy, but we haven't really talked much about the penile anatomy. So when we're talking about dorsal versus ventral, the dorsal aspect is going to be like the posterior aspect, like closer to the patient's thighs, and then the ventral aspect is going to be more so like towards the front. That's going to be a little bit like confusing with this picture here because the urethra, this is going to be like the front side of the patient. So the urethra kind of sits like on top, and then the dorsal anatomy, so like the dorsal vein here, is going to be more so like towards the back. So with the medically induced erection, the dorsal aspect is going to be like on the bottom side, and the ventral part would be where like the urethra is. So this picture would be almost like if you're looking like from the patient's back side forward. So what we're looking at mainly for here is our dorsal vein, like we had said, towards the back side. We're also looking at the cavernous arteries. That's going to be located kind of within the mid portion of the tissue. These right here. So there's one on each side. The dorsal vein right in the middle. And then we have the dorsal arteries that are going to be a little bit easier for us to find. Those are going to be directly lateral to that dorsal vein. So here on our ultrasound picture, this is going to be our urethra. So you can see like it's towards the top of the screen, the anterior aspect of the patient's tissue. And then we can see through that penile tissue, we see our cavernous arteries kind of right in the middle, one on each side. And then we have these dorsal arteries right here, but this is our dorsal vein. So that's really kind of what we're going to be looking at. So cavernous arteries and dorsal vein definitely are going to be mandatory for that. And then what is the interpretation of this? It's variable. There's a lot of literature that says different things, but basically what we want to see is after the injection, we want to see the cavernous artery transverse AP diameter increase. And then we also want to see increases in the velocity as well. So we want to see at least a 30 centimeter per second increase. Anything less than that is going to be considered abnormal. The dorsal vein should not increase velocity, and if it does, it's going to be suggestive that there's some kind of leak in that vein. So there could be some kind of like leaking out of that vein to the surrounding penile tissue. So we want to see a dorsal vein velocity of anything less than 3 centimeters per second. And of course, like we said, if it increases from that, then that's going to be abnormal. So not super common to be performing these. These are very common in urology offices. So that is something that if you're interested in, you would be performing those routinely. Patient care, really with all of these exams, is the absolute priority. These exams are very uncomfortable. These exams can take a very long time. There are a lot of contraindications to these exams. So you have to make sure that you know what you're doing and you're getting help if you need it, and that you're listening to your patient. We never want to make them do anything that they're not comfortable with, and we always want to give them options if we have them. So please, if you have any questions about this stuff, I am more than happy to help. It's not something that you can really see out in clinic. You can't really like YouTube this stuff. These aren't really done that often. So if you have questions specifically about these exams, please, please, please come and ask.